everyone. Good evening. Welcome to Cancer Bridges General Weekly Support Group. This evening, we are so happy to have one of our graduate students who is just, amazing. We love our students. And Wendy has been with us since when? Since
May.
May. Oh my goodness, it's been since May. And we have her to the end of December. And so we're fortunate to have her. She comes to us, though, quite experienced. I'm going to read a little bit about her so you all know how great she is. She is Dr. Wendy King, and she is a tenured professor of epidemiology at the School of Public Health for the University of Pittsburgh. Her work is focused on the design, coordination, and analysis of multi-center cohort studies, comparative effectiveness research studies, and randomized clinical trials. She is currently a principal investigator of the Data Coordinating Center for 3 NIH-funded studies. She has studied obesity and its treatments, insomnia treatments, depression and anxiety, hepatitis B and HIV, and health conditions that can affect preterm infants. Her work is regularly published in high-impact journals and has been cited in national clinical care guidelines. And when Wendy was asking, what should I talk about? Because I always like to have my students do one presentation during their field placement. I said, talk about what you know best, and something that we really haven't discussed much, which is cancer research. So we're glad to have her here to share some really interesting facts and hopefully have some good conversation. So welcome, Wendy.
All right. Thanks so much for having me tonight. So tonight we're going to talk about cancer research and kind of giving insights into all the different types and hopefully give you some information that makes it easier to understand the articles that you're interested in. And I have to figure out how to forward my slides on this screen. There we go. Okay, sorry. So just to give you a little background, what do we mean when we talk about cancer research? It can include a lot of different types of studies that aim to prevent cancer. So they might be trying to identify factors associated with developing cancer, or they might be trying to reduce risk factors for developing cancer. Studies also may be trying to determine when and how to screen for cancer, or develop the criteria to diagnose and stage cancer. And then there's also studies that work on identifying and evaluating treatments for cancer, which is often the type of study that's most interesting to people who currently have cancer. There are many different types of study designs. Each study design has pros and cons. So some studies can only determine if factors are associated with each other, but they can't determine if it's a cause and effect relationship. There may be a third factor that's responsible for that association. Other studies can determine the cause and effect relationship, but they might not be generalizable to everybody. Maybe they only studied a very specific type of person under certain conditions, and it wouldn't be applicable to everybody else. And then there's different phases of studies. So first off are the preclinical studies. Those are done in laboratories, and they usually are used to test whether a treatment is both safe and effective. They can be done in cancer cells and petri dishes, or they can be done in animal models. Often mice are used for those types of studies. They're used to decide whether the treatment should be tested in humans. And the timeline is pretty long from the time that you get a good result from a preclinical study all the way to it being translated into actual treatment for humans. And then experimental studies is probably what you're all most familiar with. So clinical trials. And in a clinical trial, there's an intervention, either it's a treatment, a device, or process, or something like that, that's being evaluated in people who meet the study entry criteria and volunteer to participate. And that last part's really important because you can only generalize the results of a study to people that are like the people in the study. So if it's in a really specific subgroup, then we would need to test that same thing again in a wider population. And in some studies, everybody receives the same intervention. Some studies use pre-selected selection criteria to determine who gets the intervention or what intervention they get. And in a randomized clinical trial, approximately half of the participants are randomly chosen to receive the intervention, and then the other half are not. And sometimes they get actually a different intervention. They're the regular intervention that's already being used that isn't experimental, and they're called the control group. And actually, you can randomize into 3 treatment groups too. So So usually it's half, but sometimes it's a third or another grouping. Then there's observational studies. Now, observational studies are interesting because there's no specific intervention that's being done as part of the research study, whether instead the researchers are observing people going through their natural environment or even going through their regular clinical care. And they're measuring a lot of things before they undergo or at the beginning, and they're following them over time. So researchers observe participants in their natural setting. They may or may not receive an intervention via regular clinical care, and they can evaluate various factors and whether they're related to developing cancer or surviving cancer. So what are kind of some pros and cons or differences between observational and experimental studies? In observational studies, you can only determine if factors are associated with each other. You can't definitively determine whether there's a cause and effect relationship. In experimental studies, you can determine that cause and effect relationship because you know that what people are like before you intervene, then you intervene, and then you measure the difference, and you have the people you did one intervention with versus the other. And especially if you use randomization, that lowers the chance that other factors than the other intervention are responsible for differences in outcomes between groups. And so if you were to instead let people choose what intervention they wanted, you'd have a hard time teasing out, is the difference between groups because of the intervention, or are there differences in the types of people that choose one intervention or the other? So by randomizing, you get rid of differences in those groups, differences maybe by age or by gender, sex, or by income level, or by cultural preferences. So that's why randomization is so important in the clinical trial. Experimental cancer research can test whether a new treatment or way to prevent cancer. It can test the effectiveness or safety of a new drug or combination of drugs, or a new way of giving a treatment, for instance, radiation therapy versus surgery. And experimental cancer research can also test lowering the risk of reoccurrence, well, that is the cancer coming back, or relieving side effects of cancer or its treatment, because as you're all aware, although it's, cancer itself has negative health effects and influences how you feel, often the treatment can also make you feel pretty crummy. And so a big goal of cancer treatment is to try to minimize the side effects. In terms of experimental studies, you may have heard of these terms, or if you're reading articles, may come across them: double blind, single blind, or open or unblinded. And this has to do with who knows what. So in a double blind randomized clinical trial, both the participants and the researchers do not know who belongs to which group. So for instance, I'm involved in a double-blind randomized clinical trial for insomnia right now, where half of the participants are getting trazodone and half of them are getting a placebo pill. But the clinicians who are treating with them and meeting with them weekly don't actually know what group they're in, and the patients don't know what group they're in because the placebo pill looks identical to the trazodone pill, and only the data coordinating center and the pharmacists who don't directly treat the patients know what group the patients are in. And that helps reduce any differences based on, if a participant obviously knew they weren't getting the real drug, they'd be less likely to believe that it would work. A single blind randomized trial, that's when the participants don't know whether they belong to the intervention group, but the researchers do. So sometimes it's impossible to blind the clinicians or researchers working with the patients from the treatment. And then an open unblinded trial, that's when everybody knows. They're still randomly assigned to each group, but then once they're randomly assigned, they know. And an instance of that might be if it's a behavioral intervention. And so if one behavioral intervention is diet and another is physical therapy, it's obvious what group you're in by the intervention you're receiving. There's no way to hide that. And then I'm sure you've all heard of the different phases of clinical trials. And so there's 4 phases, official phases. And the first one is very early on. It just tests whether a new drug, treatment, or treatment combination is safe for people. So after a preclinical study that's maybe done in mice or in cells, they move on to this phase one, and it's a very small sample size because, again, they're not sure if it's safe. So they want to be very careful not to expose too many people. Those people, why would they be willing to do a phase 1 study? Well, they are the very first people on Earth to get to experience that treatment. And if they don't have another treatment that's working for them, they may be willing to take the safety risk. But it is, again, very small, usually 10 to 30 people, and it can last from several months to a year long. It's usually pretty short-term safety that we look at. And then assuming the phase 1 trial shows that the drug or the intervention is safe, it can move on to phase 2. That's looking at how safe the treatment is, as well as how well it works on a specific cancer. So it usually has 2 or more groups, and group 1 would get the standard treatment, and group 2 would get maybe the standard treatment plus the new treatment, or maybe only the new treatment. Another design could be that group 1 gets 1 dose and group 2 gets a different dose, because they're sometimes trying to figure out with the same drug, what is the best dose. And the phase 2 trials generally last about 2 years. There's quite a bit of variation in that, but they usually last longer. So in addition to figuring out how well they work, they're measuring safety over a longer time period. And then only if a phase 2 trial does well, it shows that it has a good safety profile and it looks promising, it looks effective, then they would move on to a phase 3 trial, which is much larger. It often includes, 1,000 or thousands of participants. And again, that's comparing the new treatment that has good results in phase 2 with the standard treatment. Does it work better or have fewer risks and side effects? So maybe it works equally, but it has fewer side effects, or maybe the side effects are similar, but it works better. It really just needs to be better in one of those 2 regards to be worthy of maybe replacing or being an alternative to current treatment. And these studies usually last several years. So that's, again, why it takes so long to get from preclinical studies all the way to treatment for humans that you can get. But if the results are positive from phase 3, then the researchers can apply for FDA approval of their drug, so doctors are able to prescribe that drug. So you may be on a drug that was approved right after a phase 3 trial showed it did well. So then why is there a phase 4 at all, right? If the FDA can approve something with phase 3, why do we need phase 4? Well, a phase 3 trial, even though it has 1,000 or more participants usually, it's still somewhat limited. And we know that the more people and the more time people are on any treatment, the more we learn about it and the better we understand it. So 4 phase trials actually done usually after FDA approval, and it tests whether the benefits and the risks are the same as the phase 3 trial. So now that we have data for a longer period of time among more people, does it look as good as it did in that phase 3 trial? And usually it does. But it also can look at longer term effects, and it can also look at effects in more subgroups. It may find out when we have enough people to look at more groups that we find it actually does better in some groups than others, and maybe we would change who it was recommended for. And you probably have heard at some point of the FDA revoking approval for something. So if a phase 3 trial shows it looks good and the FDA approves it, it can be prescribed. But then if there's a later phase 4 trial that shows, oh, it's actually more dangerous than we understood, or it doesn't work as well as we thought, it can be revoked. And that can be terribly frustrating if you're a patient taking a drug that was approved and it's working for you and you weren't having awful side effects and it was revoked. I've actually talked to some members at Cancer Bridges where that happened. But the problem is the FDA has to make decisions based on a very large population. They can't do it individual by individual. And so once in a while that does occur. So we've talked a lot about experimental studies, but we learn so much about cancer from observational studies as well. And there's 4 types of observational studies. And I didn't even realize till I put the slide together that they all start with the letter C. So we have case reports or case series, cross-sectional studies, case control studies, or cohort studies. So I'm going to go through each of these and try to explain what they are. So case reports or case series, that's looking at individual patients and really trying to understand their history. So usually this is when a physician would write a report for a journal that has detailed information about either a single person's medical history that was really unusual or provided insight they thought other doctors really needed to know kind of what happened. And maybe they did had an unusual response or an unusual treatment worked for them. And they think it's, even though it's such a small sample size, right? Maybe just 1 people or maybe a small group. That's called case series. If there's a few people in a similar situation, they write that up because it's very intriguing, novel, and they think it's worth getting the word out. So it's interesting because usually it's something people haven't thought about or heard about, But, and it's really good for helping doctors think of new ideas for future research, but you can't use the results of a case series or a case report to decide, oh, my patient should go on this treatment, or I should do what this doctor did. It shouldn't be used to select treatment for an individual. It's really meant to generate further ideas for research. And then there's cross-sectional studies. And so cross-sectional, if you kind of think of a cross-section, it just means you're measuring the risk factor or the exposure at the same time as the outcome. So an example of that would be is a certain medication that people are taking associated with having liver cancer. So if you pull a group of people and yes, no, they have liver cancer, yes, no, they're on their medication. If you find the group with liver cancer, 3 times as many of them were on the medication, you could show that taking that medication was associated with liver cancer. But you can't determine cause and effect because you don't understand the timeline of when they were on the medication, at what dose, for how long, and how much, whether that preceded them developing liver cancer. So it gives us ideas, but again, it's kind of like the most basic first stage of research. So it helps plan future studies, but can't prove anything. And then case control studies are interesting. That's where you have a case and a control. So you have 2 groups of people. So the cases would be somebody with a particular type of cancer, and a control would be somebody without that type of cancer. And sometimes you can match them on a lot of characteristics like their age and their sex and their race, so in their education level, so that the 2 groups are as similar as possible besides their disease status on kind of like basic characteristics. And then you try to see how they're different. What factors that may explain why one group has cancer or not are those different in those 2 groups? And it's a form of a retrospective design, because you're looking in the past to try to understand their exposure profile. So you may look for differences in their lifestyle or difference in their genetics. Differences in, lifestyle would be diet and exercise and sleep patterns, all those types of things. And so it's a good way to try to find out if you can see if things that from their history differ between those 2 types, those 2 groups. A cohort study is where you get a group of people, in this case for cancer research, it would be people that are cancer-free, and you follow them over time, and you measure a lot of risk things that are kind of known to be risk factors for cancers: behaviors, genetics, other comorbidities, medications, environmental exposures, and then you follow them over time to see who develops cancer. And you're looking at factors and if they're related to developing cancer or not. And of course, it would be a specific cancer because we know that what causes cancer differs by type of cancer. And so you can look at nutrients, exercise patterns, anything that could be an action to prevent cancer. You're trying to find risk factors for developing cancer. And so, what are the pros and cons of both? A cohort study can carefully measure many exposure. We call them exposures, but like anything that's a risk factor, right? With standard measures. So you're starting at the beginning with a group of people, and the researchers come in and do all these measurements. They can do them all the same way. They can use really good measures. But, this type of study is better at getting closer to understanding if it's a causal relationship. You still need an experimental design to confirm that, but you have a much better sense that it's causal with a cohort study. However, they take a really long time, because you imagine you have people without cancer and you have to wait till they develop cancer. Well, you need a huge sample size and a long time to get enough people with cancer for that to work out. And so they're very expensive. A case control study is comparatively, compared to a cohort, it's very quick and inexpensive and easy. And it's really good for studying rare diseases. So if there's a rare form of cancer, you wouldn't want to do a cohort study because not enough people would go on to develop it in your cohort. So that's why case control study can be so helpful. But the results of a case control study are often used to justify a more costly study design, like an experimental study or a cohort study. And then again, I've talked about this already, but I just want to really get this point down that you have to think about the generalizability of study results. So does the relationship between a risk factor or treatment and an outcome like getting cancer or cancer remission or reoccurrence differ in different groups? So for instance, you might have heard the news, I'm trying to think of what year it was, but a couple decades ago now, work that actually came out of the School of Public Health at the University of Pittsburgh showed that there was a relationship between going on hormone replacement therapy and developing breast cancer. It made national headlines. You know, that the amount of prescriptions of hormone replacement therapy took a deep dive in 1 year. You know, there were more than half the women that had been prescribed hormone replacement therapy in the year before were no longer prescribed. There were a lot of doctors that were afraid to prescribe it. But that study was done in a cohort study that wasn't designed to measure that association. And they didn't really account for different age groups of the women on hormone replacement therapy. So research since then has shown that hormone therapy is much safer when a woman is younger than when a woman is older. And so the effect of hormone replacement therapy on risk of breast cancer varies dramatically by the age of the woman. So that's one of those things you have to think about. You know, if there's a general big group and they find this association, does it hold true in different subgroups? Sometimes it does, but sometimes it differs by group. And so when there's an effect by another factor like age, that's called effect modification. And that's really big in oncology research. So you've probably heard of personalized medicine or targeted treatment. And so often the oncologist is really looking at the individual patient and what are their characteristics to try to find the treatment that best matches them, because we do know that treatments have different levels of safety and how effective they are, efficacy in different groups. All right, so you may have tried to look up some scientific publications to better understand a treatment you're on, or just your form of cancer, or just be interested in health research in general. And if you have never been trained in how to kind of search for scientific literature or how to evaluate it, it can be daunting for sure. I can still actually remember the first class I took where we had to read scientific publications. And the first one I read, I thought, oh, this is just like so dense and boring. And, you know, it was kind of hard to follow. And it's one of those things where the more you read it, the easier it is. And the more it becomes, you know, you become very comfortable with it. But off the bat, it's not totally accessible. And then something that makes this complicated is there's many cancer research studies published every year in medical journals, and there's a lot of different journals. So how do you know what to do and what to read? Because the quality really varies. And we like to think that anything that's published is of good quality, but unfortunately, there's a huge variation in the quality of research that's published. So one of the things you want to know was the study peer reviewed? So journals that, you know, the better journals are all peer reviewed. And what does that mean? It means that peers, so other researchers who were not involved in the research study, read the study and had a chance to evaluate it and ask the author questions and maybe ask for some revisions and clarity, and deemed that this was an acceptable study that was done ethically and it was reported responsibly. So not only, you know, did they do the right data collection and analysis, but then the way they described their results was honest and true to what they actually found. And one way to kind of have a better sense of it, the quality of the article, is if you target kind of really well-known, high-quality, reputable journals. So the New England Journal of Medicine and the Journal of the American Medical Association are very high-quality journals that don't specialize in cancer research, but do publish major seminal papers on cancer research. And then they also have like JAMA, which is the Journal of the American Medical Association, has an oncology journal that's very good. Annals of Oncology, the Lancet Oncology, there's many good journals out there, but if you kind of go with one of the bigger names that they rate them by, they're called impact factor, you know, that can give you a clue that it's a better journal, and what you read in there is probably of higher quality. And then you also want to think about the number of participants in a study. So remember, when we were talking about phase 1 studies, we were talking 10 to 30 participants. And when we were talking about phase 3 studies, we're talking about 1,000 or more participants. So obviously, the more people you have in a study, the higher chance that the results the study got would be true in a bigger population. They're more generalizable. Oops. So you want to look at, again, the size. And if it's really small, it doesn't mean it's a bad study, but it does mean it may be less reproducible. So if another group were to do the exact same study in another small group, the results may be more likely to vary. The more people you have, again, the better. Then you also want to look at the duration of follow-up depending on what is being studied, especially for safety outcomes. You know, the studies with longer term follow-up give you a better idea of the long-term safety, because sometimes something looks safe in the short term, but then in the long term, we find that there's other effects. Also, the effectiveness may vary. There might be a treatment that has very good short-term effects, but you know, the 5-year effects are no better than if you hadn't had the treatment. And then again, if you're looking at clinical trials, usually in the major journals, they focus on phase 3 and phase 4 studies, but depending on the type of journal, they may be publishing the phase 1 and phase 2. I think it's less common for people in the general population to look up those studies because they're pretty preliminary. But you may be interested in participating in one, so it's good to understand them. And so a trick with, again, what we talked about is that there's so many studies coming out all the time. How can you figure out what to read and what to believe? The good news is all this research does lead to better treatment and care, but it really does make it hard for doctors and people with cancer and caregivers to keep up with all the advances and feel like they understand what we really know right now today. And there's no single study that's the final word on a type of cancer treatment. So in particular, physicians have a really hard time keeping up with reading all of the articles that are applicable to treating their patients. So that's why review articles are so important. They combine the findings of multiple studies, which help doctors and researchers and just general population have more reliable conclusions, really understanding the big picture. So you may have heard of a review article before, but they evaluate and summarize several published studies that have evaluated the same topic or question. So example, there's a review article on the effectiveness of nursing intervention among patients with cancer. So there's been a lot of different intervention studies to see if we train nurses to better care for cancer patients, do the cancer patients have better outcomes? And so there's a review where they've taken all these different studies looking at nursing interventions to try to pick out and help us learn what makes a difference and what doesn't. And then within reviews, you might have heard of the term a systematic review. So in the last 10 years, there's been a big change in scientific literature where it's much harder to get a review published now unless it's a systematic review. And that means that they were very clear in the methods they used to decide which articles to include, how to evaluate which articles to include, which to include, what information to abstract from them and evaluate, and how they were going to evaluate them, and how they were going to synthesize, kind of combine and evaluate all the results and write it up. So it's now actually common for researchers to publish a protocol, the kind of the rules they're going to follow to do their review before they even start it. And that way, the researcher doesn't kind of change their mind based on what they're finding and maybe have their own personal bias that influences what they end up reporting. And then a meta-analysis is a statistical process that is sometimes included in systematic reviews, in which they're able to combine data from multiple studies to get a better estimate of the overall trend of an association. All right, so we've talked about the scientific literature, but you know, if I'm just a regular person trying to understand my new diagnosis or my treatment options or anything about my care, probably I'm going to go to Google and try to do a search, because that's really accessible, and you don't need any special subscriptions from a university or from journals to get what you want, right? So you might just go to Google and type in a treatment or a diagnosis and read what it has to say. And the internet is a very useful tool for people with cancer and their loved ones, right? It can help you find cancer information that's useful for your care and treatment. And it can connect you with other patients and caregivers, maybe even an online support group. But it's really important to remember that online resources can include false or outdated information. So anybody can put information on a website. You know, if it's a Cleveland Clinic or Mayo Clinic website, or University of Pittsburgh website, you know, or UPMC, it's probably good content. But there's a lot of content out there where people just create their own cancer webpage or, you know, information, and they don't have a degree and they're not evaluating it carefully. And then often those types of websites don't get updated regularly. So if you do get cancer information from UPMC or Cleveland Clinic or Mayo Clinic, usually at the bottom, it has the date that the information was last updated. And usually it's within the last year. So they're constantly looking at the information they're providing to the public as a service, and they're updating it based on the new information that they've learned over the last year. So what are some dangers of using online resources to understand cancer? So the main thing is that not all of the information is correct, right? Some of it's not reliable. Also, searching for information about your symptoms or your particular type or stage of cancer online might make you feel worse emotionally. So it's, you don't want to kind of hide from the truth, but it's important to sometimes get the truth from a provider that can talk you through that truth and help you understand it better. Otherwise, it's easy to kind of read the worst case scenario and get pretty freaked out. And then you might think your condition is not as serious as it is. So you might look up at your symptoms and kind of self-diagnose and decide, oh, I don't really need to go to the doctor. I just have this, it's okay. And then maybe it is more serious. So sometimes it delays people getting treatment because they kind of misdiagnose what they have for something less serious. Also, online searches may give you a long list of possible answers to your question, and then it's up to you to figure out what's right. So, if you put it, there's a lot of symptoms that can come from many different conditions. So, you say you have headaches. Well, you may have tight shoulders, or you may have, an aneurysm or a brain tumor. Like a headache can mean so many different things. And so, how are you supposed to figure out what your symptom means? And that's why it's really important to go to a health professional to talk about it. Doctors can come up with a logical diagnosis and a tailored treatment plan by integrating your information, your family history, your physical exam, and results from your diagnostic testing. So they get input from a lot of important sources to try to figure out what's going on versus you kind of looking at a list and trying to figure it out. So it's just important to exercise caution when you consider information from the internet, and particularly social media, discussion forums, and websites that are not reviewed by medical professionals. And it's not that, it's not dangerous to take a peek at some of those things. If you're interested in finding a group of people that have your condition and they're supporting each other, and once in a while somebody suggests something, it's not that you have to turn your eyes away, but you want to, not use them as the same, take it with a grain of salt, and don't treat it like a recommendation from a medical professional, but rather write it down and bring it to your next appointment to talk to somebody about it. So being evaluated by a doctor or medical professionals is crucial, part of the diagnosis and treatment process for cancer. And then some of you may be interested in participating in a research study. I've actually participated in, I think, 3 myself, and my daughters participated in several as well, because living so close to the university, we get advertisements constantly for them. And I feel a little bit obligated that I should participate in some, given that I do so many myself, and I'm always trying to get people to participate. And it's actually kind of fun, I think. So, it may be something you're interested in, either because you just want to kind of help researchers in general learn more, or because you think you might personally benefit from it. And there's different types of research where those are, have different possibilities. Some research you should always, go through an informed consent process where the researchers explain the study to you very carefully, and they are supposed to be very upfront and honest about the risks and the benefits to you. And sometimes they'll say, like, the benefit is you're helping with, us gain medical knowledge, and we can't guarantee any direct benefit to you. But other times they say, well, we think we're studying this new treatment because we think it's promising and you may benefit from going on it. But, never can they make any promises about that. And they're always, very truthful about the risks as well. And there's good institutional support for making sure that any study goes through very careful evaluation by people that are not the researchers doing it, to make sure that they covered all their bases and were very clear about the risks and benefits. So you might want to talk to your physician about research if you're interested in it. You could ask, what publications can I read to learn more about my cancer type? Are there medical journals that focus on the type of cancer that I have? That might be, a more likely place where I'll find helpful information. If you see a study about a new treatment, you could ask, is this treatment related to my type of cancer and the stage of cancer that I have? Or if you read about a study where people like me included in the study, are the results generalizable to me, possibly? You could ask your doctor, what do you think about me joining a clinical trial, and get their input as well. And then you can ask them, do you know of any clinical trials where I'd be a good candidate? I might be a good participant. Where are they located? How do I find out more about them? And so I'm going to stop sharing my screen now. And that was a lot of information. So I hope that I can answer your questions now. Or
I'm going to stop the recording and then I'll unspell it you. Thanks, Wendy. That was awesome.